Okay. Just going to open up the presentation. Okay, can anyone see that, the presentation now? Sorry, I can't see any of the chat.
Yeah, can see.
Yes, that's visible. Thanks, Rachel.
Okay. So I think Rebecca is going to let anyone in if anyone turns up from now, but I'll just start the presentation. So hello everybody, my name's Rachel. I work as a public health registrar currently in Birmingham City Council, work with Mary Orware and Rebecca Howe-Jones. So I've been working over the last year really on an oral health needs assessment. So in Birmingham, it's been covering Birmingham and Solihull, but today I'm going to be focusing on Birmingham. So I'm not sure what everyone's background is here, but if I just let you know about a needs assessment. So it just looks at the current health, so in this case, oral health of the population of Birmingham. So that's children, adults, older adults. It looks at the services and then we see which gaps there are and what recommendations we could put in place to try and improve the oral health for Birmingham. So today, so we've got an hour, I'm not sure it'll be a full hour, but we're going to look at oral health and why it's important, look at the oral health picture of Birmingham, we look at children, adults and older adults, look at services, particularly general dental practice and people being able to access those services. I'm also going to be using Menti, if that's okay. So you could either use your computer or your phone. The code is there, but when the questions come up, the code will be on the screen as well. And really, it'd be great for me to get me and everybody else working on this to get an idea of what people already work with in oral health and see what your kind of views are on recommendations or what you think would work. Then we're going to be looking at services that are available. I've done a few things with Citizen Voice, so we can go through those and look at the draft recommendations. So we just start off really with a quote. This is by Richard Watt. He's a professor and consultant in dental public health. So he says the mouth really is a marker of the people's social position and future disease risk. So this really highlights the established link between poor oral health and deprivation, and that this stretches throughout the life course of a person. So it starts in early childhood and it gets kind of worse throughout the life. And it also links that oral health is related to poor oral health at the beginning of life is related to poor oral health later on, but also to your general health and your general health risk as well. So, this is the first Menti. I'll just start it here. So if you could log on to Menti, if you're able to use it, just join at menti.com and put the code in 55336135. And I just thought I'd get a general view at the beginning at why you think oral health is important to Birmingham. So you've come to this talk about oral health. So I just want to get your views of why you think it's important for the citizens of Birmingham. So I'll just wait a moment for those responses. Okay, so we've got a couple here. The first is due to links with health inequality, which we know is well-established links with health inequality. Also pain and stigma associated. Prevention rather than waiting for pain and tooth loss, that's really important. I don't know if it's just taking a moment to load. Oh, here we are. So high dental decay in children, lots of immigrants and asylum seekers living in other places. Oh, sorry, there's something people can do about it, long-term consequences, important to understand the widespread, to advocate for appropriate resource and prevention. Okay. Fantastic. Yeah, some great ideas there. So I'm not from an oral health or dental health background myself. So doing this needs assessment has really opened my eyes to the importance of oral health and oral disease, especially with the links to wider health and to links with vulnerable communities as well. So yeah, these are all fantastic. Let's move on. Oh, here with some more. The essential for people with learning disability and autism, oral health is essential and demonstrates health inequalities. Prevention is key. Long-term consequences of poor oral health, which is true. Integral part of general health. Okay, so carry on. So these are just some views that I had as well. So we know that it's a public health challenge affecting a lot of people. So in 2022, the WHO estimated that 3.5 billion people globally are living with oral disease. And obviously this is disproportionately affecting people in developing countries, but here as well, there was an oral health survey of adults in general practice in 2018 in England, and it showed a third of adults had tooth decay, half had experience of gum bleeding, and 20% were in pain. So it's a significant problem affecting a lot of people. And it also affects people throughout their life course. So we can see that there are inequalities in childhood with oral health, and these are reflected throughout the life course. It's good to embed oral health behaviours within an early age. But if so also we look at older people and the other end, we can see that oral health and oral disease disproportionately affects older people, and it's not a natural part of aging. There used to be that kind of most older people just didn't have teeth, but now people are living with their natural teeth longer. So it's important to be able to maintain good oral health later on in life. And like we said, there's a strong relationship between oral health and deprivation. And socioeconomic status isn't just related to the prevalence of oral health, but also the severity of oral health disease. So it's really important to acknowledge that and help try and reduce that. And there's also a strong relationship with reduced education and poor oral health and household income. And we can see that poor oral health doesn't just affect the mouth and teeth, but it also has an impact on wider health. And there's some well-known relationship between oral health and cancer, pneumonia, COPD, cardiovascular disease, malnutrition. And we know that the risk factors for poor oral health are shared with other non-communicable diseases such as obesity, diabetes, and cancer. And there are lots of consequences to poor oral health as well. So we know that it affects eating, communication, sleep, taste, but it also has wider implications on job opportunities, confidence, well-being. And we know that there are effective interventions, and the WHO said that most oral health conditions are largely preventable. And 9 out of 10 hospital tooth extractions in children aged 5 and below are from preventable tooth decay. So there's definitely work we can do with prevention of oral health disease to reduce these consequences for children and people later on in life. So this is just one of the stats that's quoted quite regularly, but there's a survey of 5-year-olds in England, which is done every other year, and it looks at tooth decay at 5-year-olds. And nationally, we know that 1 in 4 children have evidence of tooth decay at the age of 5, and this is mirrored in the Birmingham picture as well. And significantly, children living in the most deprived areas are 3 times more likely to have dental decay than those living in the least deprived areas. So if we look at the effects of poor oral health, we can see that we know we said before it has an effect on function, so eating and communicating. We see that people are left with pain and infection for a long time as they're waiting to access a dentist if they're unable to get access to urgent or regular appointments routine. But it also affects things like school readiness. So we can see here this Public Health England diagram. This is from 2019, so it's a bit out of date, but we can see that it affects things, for example, days missing from school. So an average of 3 days of school were missing due to dental problems. We can see here that 2/3 of parents reported their children had been in pain with their teeth. 38% of children had sleepless nights because of the pain. And then we can see that this also impacts on parents with time away from work, but also if adults have their own dental problems, they're having time off work as well, with pain and infection and going to the dentist. So it impacts financially, and obviously there's a well-being impact as well. So if we look at how to prevent oral disease, we can see that at an individual level, there's things that can be done. So these are quite simple interventions, but they have to be consistent and become habitual. So oral hygiene, so brushing your teeth twice a day, with the second time brushing it before bed, the last thing before you go to sleep. Using fluoride products at the right dose for the age that you are. Being able to access dentistry care. So this should be on a routine basis. For children, it should be maximum every 12 months, and for adults, it should be maximum every 24 months. Avoid diet high in sugar. So it sounds easy, but we all eat sugar, so that's difficult. Stopping tobacco products and reducing alcohol. That's important for oral cancer, but also for dental carers as well. So if we think on a population level of what works, so we know that fluoridation of water works. So all tap water in Birmingham is fluoridated. So Birmingham was the first city to receive fluoridated water in 1964. And we know that there's a monetary return for £35 for every £1 spent. That's from Public Health England. So fluoridated water, the benefits, we've seen that fewer children have caries, and there are fewer admissions to hospital for extraction in fluoridated areas for children. And we can also see that there are benefits for adults as well. They also experience less dental decay, and they retain their teeth for longer. And the important part is that for this intervention is that the highest level of benefit is seen for children in the most deprived areas, and that's really important. So we can also see that there was a sugar drinks levy in 2018. So this was a levy placed on drinks with a sugar content of 5 grams or more. And we know that there's evidence of a strong relationship between sugar sweetened drinks and caries, dental caries. So the most recent evidence we've got is a study from 2023, and we saw that this levy has led to a reduction in hospital admissions for dental caries by 12% for children, with the biggest reduction in admissions for the youngest children, who are 0 to 4 years. And it's also been linked to a reduction in obesity as well. So if we look at a local area, so this is NICE guidelines for local authorities about what works. So this is what works to reduce dental caries, improve oral health. So I'll just go through these interventions. So the first one is supervised toothbrushing schemes within early year settings. So this is teachers or staff within early year settings being trained in supervised toothbrushing and brushing the children's teeth at school or in the nursery with and supervising them. So we know that this works best when it's targeted to areas of higher risk, and it works better when we're in collaboration with parents or guardians, so that we know that the skills that the children are learning in school, in nursery, are transferable to home, and they can be carried on throughout life. And with this, we can see that provision of toothbrushes and toothpaste are important as well, both within these early year settings and within other settings, for example, food banks. Another important intervention is targeted fluoride varnish programs. So if you're not aware, fluoride varnish is a semi-permanent varnish that's applied to teeth. It should be applied through NICE guidelines to teeth of children aged 3 to 18, at least twice a year. We could increase this frequency if the children's at higher risk of caries. So this can be done, and it is done within general dental practices. But say if a child may not be seen within a dental practice within that 12 months, or is seen once, then it's not being administered as frequently as it should be, which is twice a year. So there's a recommendation to think about whether this could be rolled out in the local area. And then whole school approach, that's important because there's a lot of evidence for younger early years interventions, but working across the whole school is also effective. So this could be things, for example, including oral health into policies of food and health, even something as simple as making drinking water available to all children, especially when it's fluoridated in Birmingham, making choices for children to have sugar-free foods and drinks, especially in vending machines, and importantly, including oral health within the curriculum, so including it within the education, so the children are receiving that, linking with local partners. So we could also think about including oral health in all local health and wellbeing policies. And we know that there's a link between oral health and wider health and social health. So including oral health, not just on its own, but into those other policies is really important. These could be, for example, breastfeeding and weaning. We know breastfeeding up to 12 months is protective against dental caries in children, and healthy weaning is important. Nutrition of babies, children, and young people is important. Perhaps thinking about oral health in obesity policies, and thinking about food and drink policies within early years settings, but also wider private nurseries, voluntary sector, primary and secondary education, and then thinking about policies perhaps in for older people or people living within care facilities as well. That's important. And then incorporating oral health into existing services for children and young people, and frontline health and social care staff providing oral health advice. This is looking at opportunistic encounters for improving oral health for people. So we know that probably 50% of children are not visiting the dentist. So could we use other encounters to improve oral health improvement and prevention for these children? So could we use, for example, other encounters like for at school or for adults within addiction services or services supporting people living independently in the community? So utilising those opportunities to deliver oral health prevention messages. And obviously that requires training for those staff. So the next thing is about food and oral health. So obviously we know these two are very, very linked. So if we look at OHID, they produced Eating Healthier Guidance in 2021, and they showed that minimising amount of frequency of sugar containing food and drinks led to less dental caries. And they advised to avoid sugar at bedtime. That's when saliva flow is reduced. And they also looked at feeding the young children aged 1 to 5, and they showed that children do consume high foods that are high in sugar and fats between these ages of young years 1 to 5, contributing 30% of their daily energy intake. And foods that are manufactured directly for young children aged between 1.5, 2 years, we can see they've got quite high sugar as well. So for example, sweetened yogurts, they contribute some 20% of free sugars to children within this age group. So if we look at those foods that are directly marketed towards young children, they have often high in sugar. And we can see in 2016 to 2019, the consumption of free sugars exceeded the government recommendations for all age groups. So not just for early years, but for older children as well. Just thinking wider, as a city, Birmingham have got a larger proportion of fast food outlets than England. So for Birmingham, it's 30% of their food outlets, and then for England, it's 26%. And this is important because fast food typically have a lot of fizzy drinks and high sugar desserts. So if we have more of those in Birmingham, people have got higher access to those drinks with their meals. And we can also think about the link between food and oral health and food insecurity. So we know nationally that food insecurity has increased. It was 7% in 2021 and 17% in 2023. And we know the quality of food within houses that have food insecurity has a higher level of sugar. So as that's increasing, the sugar in those households are increasing as well. So this is another mentee. So I just thought, based on everything that we've been talking about, perhaps in your own work streams or where you're working, whether it's in the council or out the council, what work is currently being done to improve oral health? I'll just start that mentee. So if you could log back in, and the code is at the top there, and just think about what work is already being done within your area or that you know of, you've heard of, to improve oral health. So we can see here there's provision of free toothbrush and toothpaste, which you know is evidence-based and works. Working with OHID to try and implement water and milk-only policies in primary schools. And I know that's also been trying to, that they're doing that within the Oral Health Improvement Network in Birmingham and Solihull. distribution of toothbrushes and toothpaste to various settings. And I think that's important to do it not just in early years, but across different settings within Birmingham. Oral health toolkit for parents and teachers. This one, commissioning of ortho industry. Local dentists providing preventative messages to patients. And that's important. Some primary and secondary prevention within dental practices is important. Just wait to see if there's any more. Oh, that's good. Was in hospital recently and given free toothbrush and toothpaste. And actually, I used to be a doctor working in Warwick Hospital, working on geriatrics, and I did an audit of oral health, and only 5% of people on the ward had toothbrush, even though they're in the cupboard, they're available. Free toothbrush and toothpaste. Okay. So what I'm going to do now is just quickly look at the population of Birmingham. Then I'm going to look at the oral health of Birmingham, the services available, and then think about what recommendations we could do to improve oral health within Birmingham. So if we just look, Birmingham's population is at greater risk of oral disease. And also we can, if we have a look at the population, it can help us target recommendations to improve oral health in the best way for the population of Birmingham. So we know Birmingham's got quite a young population, with over a quarter of the population, 27.3%, under the age of 18. So that's important in targeting interventions. We know there's high levels of deprivation. So here we can have a look at a graph which looks at IMD decile. So we can see 41% of people in Birmingham are living in areas, the top 10% deprivation within the country. It's ethnically diverse, and we can see later that that impacts on the prevalence of oral health in children. And there's a larger, if we look at the older population, there's a larger proportion of the older population in Birmingham that are requiring long-term support. So that impacts on the recommendations that we need to help with older people in the community. And if we look at the split between nursing care and residential care, just care home, there's more people within nursing, so that's important as well. So if we look at children's oral health, so we can, this is a graph looking at dental decay in 5-year-olds in Birmingham and England. So when we look at dental decay, there's a 5-year-old survey, I said, that happens every other year that looks at local authorities in Birmingham. They take a sample of schools and then they examine the oral health of 5-year-olds. The thing that's used often as a comparison, an outcome that's comparison, is looking at experience of dental decay. So this looks at, when we look at children's teeth, they look at if they've got any teeth that have got caries or any visible decay, any teeth that are missing due to previous caries, or any filled teeth due to caries. So it's their whole experience in their life of decay. So this is looking from 2012 to 2022. The green line is England and the blue line is Birmingham. So we can see that Birmingham has had consistently higher levels of prevalence of dental decay from 2012 to 2022, although the gap recently has narrowed massively. But still it's roughly around 25%, which is 1 in 4 children have had experience of dental decay at 5 years. And also important, this is national data, it's not Birmingham data, but decay is linked with deprivation. So we can see here that the prevalence of dental decay in 5-year-olds is about 35% of 5-year-olds in the most deprived group, and it's about perhaps 15% in the least deprived. And every quintile you go down, the prevalence of decay decreases. And this is West Midlands data looking at ethnicity groups. So it's not per Birmingham, it's for West Midlands. But we can see here, if we look at the left, figure 7, we can see broad ethnicity groups here. So the group with the highest level of decay, this is for 5-year-olds still, is the other group. And then the second highest within the West Midlands is Asian or Asian British. The lowest is Black British, Caribbean or African. And if we look at figure 8 on the right hand side here, we can see this is the breakdown, the ethnicity subgroups within the Asian group. So we can see that the group here with the highest level of decay is the children, the Chinese group, and then Pakistani after that. And if we just quickly go back to this graph here on the left, we can see, just have a look at the white group, because I'm going to look at the breakdown within that group on the next slide. So we can see here, this is the breakdown by the subgroup within the white ethnicity, that we can see that children in the Irish group, they're about 30%. So 3 in 10 of those children have got evidence of dental decay at 5 years. And then the Gypsy Irish traveller group is quite high. That's about 58, 60% of those children have got evidence of decay. So now if we just quickly look at adult oral health, unfortunately, there's no survey or data that looks specifically at Birmingham's adult oral health. So this is generally national data just to have a look at how things are for adults. So we can see that the link with poor oral health and deprivation continues into adulthood. So this looks at the percentage of adults with no natural teeth per deprivation quintile. So we can see that the people in the most deprived group have got a higher percentage of people with no natural teeth compared to those in the least deprived quintile. It's about 4 times higher. And the next is looking at the pattern of dental attendance. This is linked to retention of natural teeth. So here, this is from the Adult Oral Health Survey 2021, but we can look at the proportion of adults who reported they had at least 21 teeth, which is the number of teeth needed for adequate dentition. So the people that have at least 21 teeth. And if we look here on the left, these are people who have regular checkups or occasional checkups. So we can see that people who have checkups are more likely to have at least 21 teeth than those who only go to the dentist when having issues or have never been to the dentist. So it's important to have regular checkups. And then this is looking at impacts for adults with oral health problems. So we can see what we were talking about earlier, that there are problems with being unable to eat, with well-being, feeling embarrassed, difficulties with pronouncing words and communication, unable to function. But importantly, we can see that nearly 50% of the adults within this survey had at least one or more of these impacts. So showing that oral health is significantly impacting on these adults' lives. And then when we look at older people, again, there's no real data for mildly dependent older people in Birmingham. So mildly dependent older people, we're looking at older people living within the community with some care needs, but not needing to be within care facility. So I thought I'd just put the data for England here, which just gives us an example of what the needs are for these older people within the community. So I've just highlighted here, we can see that 70% have visible plaque, which makes you more likely to have gum disease and dental disease. And we can see that 13% of people with partial dentures needed replacement, 14% with full dentures needed replacement. So there's an unmet need there. We've been able to access services and replacing dentures. And we can see that people in urgent need of treatment, there was 3% in urgent need of treatment when the survey was taking place. So whether these people were able to access urgent dentistry or not, we're not sure, but we can see they have that unmet need. And when we look at older people within nursing homes and residential homes, we can see that CQC did a report, Smiling Matters, in 2019. They went to 100 different care homes. Some of those were in Birmingham, most of them weren't. But what they looked at oral health policies, or the oral health of older people, and to see what the problems were. So they found that 50% had no policy to protect the oral health of people in the care home. Staff weren't trained. 40% they had no training to support daily oral health care. We could see that there was also difficulty accessing care for this population, difficulty accessing routine and emergency dental care. So just quickly looking at oral cancer. These are the rates of oral cancer. This is pulled from fingertips, calculated by OHID. So this is England against Birmingham. So England is the black line and Birmingham's the blue line. So we're looking between 2007 and 2019. So we can see that consistently Birmingham has a higher rate of oral cancer registrations than the national average, even though the gap is narrowing from 2013. And then if we look at mortality rate, we can also see that mortality rate is higher in Birmingham as well. So again, Birmingham is the blue line here. So it's higher between 2008 and 2018 than the national average. And here we can look at oral cancer mortality rates across the region. So we can see the city that's has a higher mortality rate is Coventry, but then Birmingham is the city here, or the area, the West Midlands, with the next highest mortality rate for oral cancer. So just thinking about what we've just gone through, the data there about oral health, I just thought perhaps I could get your thoughts about oral health of Birmingham. Was any of that surprising, or is it what you already knew or thought of, or is there any data that you thought should be in there? So it's another Mentees. The code is at the top there again. So if you could log on to Mentee and use the code there. Oh yeah, so we've got a comment there about smokeless tobacco and demographics. Yeah, about looking at food in hospitals. Yeah, okay. So the question, are people living with learning disability and autism, how they are supported? Yeah. Okay, so I'm going to talk about services next. Oh, sorry, there's a comment here. It's pretty poor and disappointing issues in access to NHS dentists, learning disability population, autistic population, food in school, poor, especially secondary. Yeah, I've heard that. I spoke to someone recently they were talking to secondary schools and how physically and practically it was difficult to get everybody to sit down. So a lot of the food was grab and go, and that food was tend to be less healthy and more difficult. Access to dental service is very challenging in Birmingham. Getting appointments is difficult. Yeah, this is common and especially highlighted in Health Watch reports as well. I'd be interested to know what action is being taken in Solihull. I know there's action through the Oral Health Improvement Network in Solihull in terms of oral health promotion. Okay. So next I'm just going to look at accesses to services. So I haven't got much time. I'll just run through this. So looking at dental checkups, so looking at accessing general dental practices. So I know for adults, there's a maximum recall time of 24 months, but if you've got a higher carer's risk, it can be less than this. And for children, it's 12 months. And dental visiting the dentist, it's important to be able to have your teeth checked and have treatment, but it also is a good opportunity for oral health promotion, have some chairside prevention as well. So this is data from NHS Digital. So this is looking at children visiting the dentist and the percentage of children seen by a dentist in the previous 12 months in England and Birmingham. So we can see here, Birmingham's is the red line and England is the blue line. So it's from 2015 to 2023. So we can see that Birmingham has a lower percentage of children visiting the dentist in the previous 12 months consistently. We can see a obvious dip here in 2020 to 2021 for COVID. And we can see that levels are increasing, but not back to what they were. But even before that, it was 50%. So still 1 in 2 children not visiting the dentist regularly that they should. However, I'd just like to say this doesn't include private practices. So we don't know how many children are visiting private practices. Thinking about vulnerable groups, so looked after children in Birmingham, we know they have a lower access. There's their priority to be able to visit the dentist. So if we look at the stats here, this is from the Gov website. So we can see that in 2019, 86% of looked after children in England saw the dentist in the last 12 months. And in Birmingham, it's 89%, so it's better. We can see an obvious dip here in 2021 with COVID, and England's rates 2023 are 76% of these children seeing the dentist, so it's improving, whereas we can see Birmingham still quite low at 50%, and the same is in Solihull as well. So this is looking at bands of treatment that people are accessing. So this is from NHS Digital. So I'm not sure if everyone's aware of the banding system, but when you go to the dentist, your treatment is based on banding. So band 1 is more kind of preventional, activity. So for example, examination, assessment, advice, and x-rays. And then if you require treatment, it's more band 2 and band 3. So these are things treating off dental disease. So fillings, root canals, extractions, crowns, dentures. So if we look at this data here, this is from 22 to 23 for Birmingham and England. Birmingham's in the red here and England's in the purple. We can see this higher proportion of people in Birmingham needing to have band 2 and 3 treatments, which shows that having more treatment of oral disease rather than the national average, where there's more people just accessing band 1, which is more of the prevention and routine checkups. We can have a look at the reduced awareness of needing to go to visit the dentist regularly. So this is from the GP survey in 2023. It looks at dentistry as well in this GP survey. So these are the results for, so that they asked respondents, did you try and obtain a dental appointment in the last 2 years? If they didn't try, they asked reasons why. So we can see here, we've got for Birmingham and Solihull, it's not separated. And then for England. So we can see highlighted that people in Birmingham, there's a higher proportion, 28% of people in Birmingham rather than 21% in England, felt they just didn't need to visit a dentist regularly. So we can see an area there for education on being able to that you need to go to the dentist more regularly. And also the other highlighted area here is that people in Birmingham found that the NHS dental care was too expensive. So higher proportion in Birmingham than England felt that it was too expensive. And then this is just a graph I put together looking at the cost of dental services and inflation since 2015, just because the costs are kind of increasing every year. So we can see that the cost of dental services has been consistently above general inflation since 2015. The next, just looking at fluoride varnish rates. So these are rates within general dental practice, and they're looking at the rates of children who are indicated to have fluoride varnish, so those from age 3 to 18, and whether they've had fluoride varnish applied in the last 12 months in Birmingham and Solihull, this is the data for. So the first graph on the left here looks at fluoride varnish rates for these children. So each bar represents a dental contract in Birmingham. So really the reason I put it in is to look at, there's a wide variation in the dental varnish, in the fluoride varnish rates here. So we can see some practices are not providing any fluoride varnish, some about 5, 10, 15% of the children they should be providing varnish to. And then some are nearly, 90, 80, 90%. So it just shows there's a wide variation in the practices that children are visiting. And actually, if we look at the graph on the right here, we can see these are the rates compared to other places, other ICBs. So Birmingham and Solihull is actually the second highest rate, so doing quite well really compared to other ICBs. So just thinking now about what can be done to improve oral health care in Birmingham. So just another mentee, if that's okay. So just thinking of, if you could log on and use the code again, and just think, what ideas have you got, big or small, that could be used to improve oral health for the citizens of Birmingham? Yeah, that would be nice, free dental treatment. Education about hidden sugar. Yeah, that would be good in a variety of settings, really, wouldn't it? Advice available at family hubs. I know that's been done through the Oral Health Improvement Network for Birmingham and Solihull. Increased community engagement, water-only schools. Yeah, I know that they're trying to do that. Supervised toothbrushing, reduce sugar products in all settings. Education, sorry, education campaign informing of link to increased risk of other health conditions. Yeah, that would be good. Water-only schools, education around flossing, cross-curricular in schools. Okay. Yeah, great ideas. This is just pictures of children brushing their teeth. And just the last one of mentees, what barriers do you think could be faced when implementing these interventions in Birmingham? For access to services? Yeah. I did actually look at I created some maps looking at areas of Birmingham that are in the highest level of deprivation and seeing whether there are dental practices in that area that they could go to. And there were some areas where there wasn't practices you could get to within 15 minutes on public transport. So low education, financial challenges, cost is a huge barrier that people face, lack of awareness, language, engagement with parents, yeah, not a priority, yeah. Especially if you've got limited funds, oral hygiene products could be low on the list. Availability of high sugar content food with low prices, that's a huge challenge, isn't it? Parents lack knowledge about this. I lack knowledge about this as well before I even started this. So normalisation and ease of access to sugary food and drinks. Fear of cost in education. Yeah, you're right that treatment for children is free. Okay. So this is just the last section. So I just did a bit of citizen feedback. So there's a Health Watch report looking at access to dentistry. I had a Be Heard survey that got about 9 responses, and that had some interesting feedback. And I also did some interviews with some head teachers from special education needs schools, because there's, like we were talking about earlier with learning disabilities, there's a lack of information and data for special education needs schools and oral health. So this is from the Be Heard survey. This was in March and April, so got about 9 responses. So I asked a few questions, but these are just some that had open answers. So this is for citizens of Birmingham. So I said, what do you find difficult when looking after your teeth? And similar things that we were just talking about there, sugary snacks, eating, sugary drinks, and then also about cost. That was a huge thing as well. Dentist costs are expensive. And then also looked at what could be changed to improve your experience of seeing the dentist. So cost as well. That was again something here. Better understanding of how the experience can trigger sensory difficulties with autistic people. And this was something that I'll talk about in a second that was brought up a lot within the special education needs schools as well. An NHS dentist that I could register with. So just being able to register regardless of accessing the dentist. And previous experience as well of different dentists that aren't good, stopping people going. So I did some interviews with some head teachers from special education needs schools, and a few things came up. So really, a big theme was that the needs of all children are unique, between schools and within schools as well. And often these schools are for a kind of wide range of children, age range of children. Need for tailored care, and also need for kind of longer care as well. Challenges around healthy diet. So some of the children had fixed diets in what they would eat, and some of these were unhealthy foods, and it was really difficult to change that. And actually, the priority was to be able to give nutrition to the children rather than not give the nutrition because it had sugar in it. The need for parent guardian engagement to be able to carry on these oral health behaviours within school, out of school, and also looking at children. It was in local authority care, they might need extra support just to keep the continuation of services within school and dentistry. They were saying there was a disjointment between those services for those children if they were moving around different areas. And this was from Health Watch. This is a report from 2022 looking at how easy it is to access dentistry for Birmingham and Solihull. And these are just some of the main themes that were there. So what we were expecting really, long wait times for treatment with people left in pain, feelings that the dentists wanted to do private work over NHS work, and people being offered private dentistry while they're having NHS dental care, difficulties finding a dentist taking on NHS patients, especially with urgent dental care, incorrect information. So I also looked at NHS website for Birmingham and phoned up 40 of the practices, and there was a disjointment between what it said on the NHS website, if they were accepting patients, and actually if they were, the information wasn't correct. The cost of treatment, so private treatment, but also NHS treatment, that was a barrier. Removal of patients from the dental practice during the pandemic, that was a problem, and challenges with people with disabilities. So just quickly, 5 minutes, just think about the draft recommendations. So completely in the draft stage, but just thinking about what we can do to try and improve and work on the oral health of Birmingham. So we know that there's an existing oral health improvement network which covers Birmingham and Solihull. They meet quarterly, and they've got a wide variety of people from loads of different teams who all work on oral health, and it's about joining this work together. But we know that there's a lot of teams and places that work on oral health that wouldn't be specifically for oral health. So, for example, in education and schools, care homes, in the social care sector. So, trying to link up these people, and through this, I've been able to do some links within Solihull with older people, social services, and the oral health improvement network. But trying to link up these networks is really important to see what's going on elsewhere, what works, and what could be done to improve that. Looking at a whole school approach. So I know some of you are saying water only schools or water and milk only schools. That's really important. That's something that's being looked at the moment for Birmingham and Solihull. And incorporating oral health into the curriculum. When I was speaking to some of the special education needs schools, 3 of them had oral health within the curriculum. So it's been delivered in PHSE every year. And they said that was really effective. So doing that for all schools would be a good idea. And looking at food policies in schools to make food healthier food more available. And then oral cancer prevention. So there's things that could be done, like, for example, in Birmingham, there's a smokeless tobacco resource that's being sent out to the Bangladeshi community through the behavioural science team, which is amazing. And also just trying to bring oral health into stop smoking services to create the link between oral health and oral cancer and smoking. And then looking at HPV vaccination rates. So HPV is a virus that can cause oral cancer. So trying to improve the vaccination rates for both children, which are boys and girls now, and within GUM clinics, sexual health clinics, that's where the two places where you can get vaccinated. That's really important. So the fourth one is increasing and promoting primary prevention in dental practices. So this is looking at utilising that opportunity within a checkup in a dentist to try and utilise that to be able to improve primary prevention and within the dental practice. That could be, for example, making every contact count, or a brief advice to stop smoking or look at alcohol. Or it could be to improve fluoride varnish rates within Birmingham for children, and just strengthening that relationship between dentistry and wider health, because they both impact on each other, like we've been talking about. And the last one is looking at older people. So we can try and increase oral health interventions for older people in the community, both within and out of residential homes. So we could use day centres to try and promote oral health interventions to keep people oral health the best it can be for as long as it can be, utilising carers that go into people's homes to deliver messages, to increase the amount of times people brush their teeth, talk about healthy food for older people, being able to access the dentist for older people. So that's important as well. So conclusion. So we know there have been improvements in oral health in Birmingham slowly over time, but it does generally remain worse. The oral health is worse than nationally. And the highest burden we know is on people living in areas with the highest deprivation. Reduced levels of access for dentistry for children and adults in Birmingham. So that's important for treatment and health promotion. And we know there's evidence-based measures that can improve oral health. And we know there's an established oral health network, so we could try and tap into that and see what we could do to improve the oral health of Birmingham. Okay, thank you. I don't know if anyone's got any questions. We've got about 5 minutes left. Okay, thank you, everyone. So I'll just stop sharing now and stop the recording. But if anyone would like access to this talk, it's going to be put onto the Birmingham City Council YouTube. So thanks for listening. I appreciate your time. And if you've got any questions, I could put my email into the chat here. Okay, thank you.
Resilience.
Sorry, Phil.
Yeah.